You're listening to the Move to Value podcast, powered by Chess Health Solutions. The Move to Value podcast is dedicated to helping healthcare providers understand and make the transition into value-based care. We do this through conversations and the sharing of innovative ideas with practitioners, experts, and leaders throughout the healthcare industry. Our mission is to sustainably transform the healthcare experience for the patient, provider, and care team by cultivating a value-oriented, compassionate, and health-aligned community. Today we talk with Rebecca Grandy, Director of Pharmacy at Chess Health Solutions, about the connection between diabetes and chronic kidney disease, what's at stake, the populations who are at risk, and what tests and interventions are available to the provider. Rebecca Grandy, welcome to the Move to Value podcast. Could you start by explaining the connection between diabetes and chronic kidney disease and why it's so important to screen for these in diabetic or for chronic kidney disease in diabetic patients?
Sure. Diabetes is one of the leading causes of chronic kidney disease. I think there's lots of reasons for that. A lack of early screening, a lack of just knowing what to do, having accessible medicines. But all of those things now, we have relatively good screenings, we have medications, and so kidney disease and diabetes is preventable. And then just from a disease state perspective, diabetes itself, the high glucoses, the inflammation, the high blood pressure, obesity, all of those things also increase your risk for chronic kidney disease. And so you'll see a strong correlation between those two.
It's also proven that minorities are disproportionately affected by chronic kidney disease. What steps do you think can be taken to address that as we start looking into our social determinants and our health equity components of the quintuple aim?
Wow, that's sort of a can of worms type of question, right? Because, when I think about minority populations or even just disparities in healthcare, I think there are lots of reasons for those. One is access. And so primary care, I think, is the solution for that. And so being able to solve access issues to primary care. There are also issues like social determinants of health issues. And so thinking through a lot of the work that ACOs are doing, like the REACH model, care coordination, social work, really being able to not only screen for social determinants of health, but to actually have solutions for those. And so I think that's happening slowly. Those screenings are starting to be incorporated into primary care. But if we can address some of those issues, I think we can solve access issues. The harder one in my mind to solve is sort of the historical trauma and distrust that comes with minorities in the healthcare system. That one's harder. But I think, having minorities go into positions where they are providers, right? So I can see someone who culturally is like me, who looks like me, who I know has my best interests at heart. I think a lot of those pipelines for minorities to be healthcare providers are really helpful as well.
Yeah, I think that's definitely true. So some of our data at Chess shows that up to 40% of people with diabetes do develop chronic kidney disease. Can you explain why early screening is so critical and how it impacts the progression of that disease?
Sure. And I feel like I have to tell a story first. So,
sure.
When I was working in primary care, one of the most, I don't know if frustrating is the right word, but definitely discouraging things is when you see someone sitting in front of you that has a chronic condition that could have been prevented, right? And I feel like chronic kidney disease is one of those preventable conditions, because when you have chronic kidney disease and you progress to end-stage renal disease and you're on dialysis, that kind of takes over your entire existence, right? Like those people are going to dialysis 3 times a week. You have to be really careful about the nutrition, about your protein intake. You have to be careful about all your medicines. You can't just go to your cabinet and reach for your ibuprofen. And so the fact that something that, can be so significant or impact your lifestyle that much is preventable, I feel really passionate about that. And so when we think about screening, it's actually one of our quality measures now for a lot of our contracts, especially with Medicare Advantage, but it's called KED, and that's the Kidney Health Evaluation for people with diabetes. It involves 2 different tests. So you have to get a blood test. most practices and physicians' offices are really good at this piece. It's part of routine blood work. Like if you have your basic metabolic panel or CMP, it's part of that. You're looking specifically at your creatinine and your EGFR, or that estimated glomerular filter rate. And that's just kind of looking at the kidneys to see, are your kidneys actually able to filter out waste or toxins out of your body? Again, primary care providers really good at getting that piece. It's blood work. The piece that I think we struggle with that's equally important is actually you need a urine sample as well. And so in the urine sample, what you're looking for is you're looking for protein in the urine, because that is not normal to have protein in your urine. And that's called the UACR, or urine albumin creatinine ratio. And that, again, that's just looking to see if you have protein in your urine, because that indicates that your kidneys are potentially damaged and they're sort of leaking, if you will. And so those two things are really early indicators that can tell us if someone's at risk for chronic kidney disease. Because in general, in the beginning, chronic kidney disease doesn't really have symptoms. It's silent. And I think I read a statistic somewhere that 90% of people who have it don't even know they have it. Because again, in the beginning, there are literally no symptoms. And so you have to screen to be able to identify it.
One of the big challenges that practices face is getting the urine test. That could be, is that the most difficult in your assessment?
That's what I found, and in my experience, like I think that's sort of been multifactorial. Probably really two factors that play into that. One, you're the primary care provider, you have a patient coming to you, and they may have 5 different problems they want to talk about. I'm guilty of this, right? Like I save up my problems and I want to talk about all the things when I get there. And so you're sitting in front of this person who may have very different priorities than what you think you want to do or labs that you want to do. So by the time you're finished addressing what you can address with them, you've just forgotten about it, right? And so unless it's really part of the process or standard of care, it's easy to forget about. So my thought would be, everyone needs to have sort of a standard operating procedure around diabetes, if you will, right? You're going to get their blood pressure. You're going to get their A1C. Well, we need to start making those urine screenings part of that sort of standard process. Allow your team members to help you. It doesn't have to be the provider. It can be the staff. It can be the lab. You can have standing orders, but it really has to become a process issue or it slips through the cracks. So I think that's one of the biggest things. The other thing that I've also experienced in primary care, and so this measure used to be a quality measure many years ago, and it was slightly different than the one we have today. But I would often hear providers say, well, my patient's already on an ACE inhibitor or an ARB. Those are the medicines that we use to help protect the kidneys, the oldest medicines we have. So you're like, why should I continue screening? That's just a wasted test. We're in a very different situation now with some of the medications we can use to help protect kidneys. So I think part of that piece is just education around those medicines and how to help patients get those medicines.
That's awesome. Well, when it comes to preventing kidney disease, what lifestyle changes and interventions do you typically recommend for patients with diabetes?
Yeah, and the lifestyle interventions are really the same ones that we would recommend to anyone to keep them healthy, part of comprehensive care. So we're going to recommend that people, try to maintain a healthy weight. If people are obese or overweight, that comes with insulin resistance. Insulin resistance comes with inflammation. And so that can lead, to damage to the kidneys down the road. High blood pressure, if you have high pressures, that's going to be in your kidneys as well. And so that high pressure in your kidneys can damage your kidneys. So you're going to try to manage your blood pressure through maintaining a healthy weight. Exercise and nutrition, right? Things we all should be doing. And then a huge one is smoking. So smoking has quite the effect on the kidneys too, because of the inflammation and just changes that happen to like your vascular system when you smoke. And so the kidneys are highly vascularized. And so anything that can affect, your vascular system is going to affect your kidneys. So same things we all should be doing. Don't smoke, maintain a healthy weight, exercise, and try to eat right.
Those are sometimes the hardest things to do.
I know, right? If it were easy, we would all do it. That's what I tell people. If it's easy, you would have done it already.
I'm really glad we're having this conversation. Can you tell me what a typical screening process looks like for kidney disease? Like, walk us through the tests, like the EGFR and the UACR, and explain their significance. You touched on it a little bit, but what does that look like?
Yeah, sure. And so, if I'm a patient coming into the office, and I would empower patients to do this as well, right? Like part of, taking care of your own health is being proactive and being an advocate for yourself. So if you happen to be a patient listening to this, or someone who has diabetes, I always encourage people to make a list of all the things you want to make sure you have done. And kidney health is one of those, but also thinking about your eye health, your feet, your eyes, your kidneys, your feet are always things you want to think about when you have diabetes. But for your kidneys specifically, most patients are going to have blood work, so they'll get a blood draw once a year. Through that blood work, they can calculate that EGFR. Again, it's calculated in mils per minute. It's mainly just like how much blood your kidneys are able to process and filter. Your kidneys are kind of like a filter, just like your car has a filter, right, with oil. And your oil filter in your car is filtering that oil to make sure all the toxins are taken out. That's exactly what your kidneys do. And so that's what that blood test looks at, is how well are your kidneys filtering. And then you're literally going to have a urine sample taken, right? So nothing invasive about that. And when you have that urine sample taken, what they're looking for is protein. Protein in your urine is not normal. There are some things that can cause it to be temporarily in there, like intense exercise, if you have really high blood sugars, infections, like if you have urinary tract infections. So sometimes you can have protein in there, and it's just transient. It's going to go away. So anytime you have a urine test and they detect protein in it, you're going to want to get a recheck in 3 to 6 months to make sure that protein in there is persistent. That's one of the pieces I find in primary care that's the hardest. Like even if they do the initial one, confirming it again in 3 to 6 months can be really hard, because again, you have someone coming in just for the purpose of getting the urine sample. And that is looking to see, if your kidneys, or if that filter within your kidneys is leaky. Should not be leaky, right? There should be no protein getting into your urine. And so that's what that's looking for. And both of those tests in conjunction can tell you if you have early stages of kidney disease and what we need to do differently.
Interesting. I never thought about leaky kidney filters before. But that makes sense. I like that. So I've heard you talk about other treatment options for kidney disease that are being used now more so than in the past. And could you elaborate a little bit more about these newer treatment classes and how they differ from some of the older therapies?
Sure. I think this is one of the most exciting parts of this conversation. We should definitely be screening early because it's preventable, but now we have way more medications than we used to have in the past. So some of the early medicines, like I alluded to, were your ACE inhibitors and ARBs, medicines historically used for blood pressure, right? So they're your lisinoprils, your losartans, endoprils, and artans. That's how you know. And we've had those for a long time. Now we have other medicines that have been shown specifically to protect the kidneys. So there's 2 groups of those in the diabetes group of medicines. So one is SGLT2s. Those are going to be your medicines like Invokana, Farxiga, Jardiance. They work actually by helping your body get rid of glucose through urination. That's part of what our body does anyway, but they lower the threshold. As part of that process, they also lower the pressure, if you will, inside our kidneys. They also decrease inflammation. So they have a lot of good evidence, these particular medicines, that they can prevent progression of kidney disease. And I have to give a shout out to my VA colleagues. I'll say these medicines work so well, even though they're expensive. This year and this coming year, it's been a focus of the VA to make sure that everyone with these early signs of chronic kidney disease actually get these medications. And if they're not getting them, there has to be a documented reason why. So I think the fact that our, healthcare colleagues in government, see the benefit of these and the cost effectiveness of them should really make a case for them for the rest of our audience as well who are in the private space. So that's a really exciting group. So if you have patients that have some degree of chronic kidney disease, you should definitely be looking into those medicines. Our GLP-1s, like Ozempic, Victoza, Trulicity, Mounjaro, the ones that are popular because of their weight loss benefit. They also have some early evidence in kidney disease and preventing that progression as well. They work by decreasing inflammation. They have lots of ways that they work, but that's one of the most common ways. So especially if someone wants to lose weight, they have cardiovascular disease, and they have some early signs of chronic kidney disease, those medicines can be a nice choice. And then now we even have a fourth class of medicines that we haven't had before. There's one called finerenone. If you're a primary care provider or even a patient listening, this is very similar to spironolactone, which we've used for a long time, except this particular medicine is more selective, has less side effects, and has clinical trials to decrease chronic kidney disease. So there are a lot of options. I mean, we could spend, a whole hour just discussing the medicines at this point.
Yeah, this is wonderful, Rebecca, because I, as a consumer of media, we're remote. We both work from home, and so because of our work, our internet usage, especially mine, now involves a lot of healthcare research. And so I also have streaming services for my television, and so my family gets a little disgruntled at these wonderful ads for all of the medications that come in, because I'm obviously in the demographic where I'm super sick. I have diabetes, I have heart disease, I have all of these other quality measures that need to be addressed because we're writing about them in marketing and communications. And they do have some wonderful commercials. And I have learned a lot about all of the names that you've mentioned. It's really funny because as you're mentioning them, I can visualize in my head these ads, which says a lot about, we could talk about media consumption and how this impacts the consumer choice, but that's for another conversation. But it was really interesting when you were talking about this, how in my brain I could almost hear the songs that people were singing. I digress. So, but as we talk about these newer treatments, of course they come at a cost, and there's often a concern about this cost. So, how would you advise clinicians to navigate this when prescribing these medications to patients? You mentioned the VA, but what about those who perhaps fall into the cracks?
Sure. I mean, the first thing is you just need to acknowledge that medicines are expensive and ask about the cost, because I think that takes away some of the shame and stigma that come with not being able to afford your medicines that our patients experience. And I think we've talked about this on a previous podcast, but there's evidence that says, 2/3 of patients aren't sharing the fact that they're having trouble affording medicines with their providers. So I think having that open, non-judgmental, like, hey, I'm going to put you on this medicine. It's expensive. Your insurance should cover it. However, let me know if it doesn't. And then when they follow back up, like, hey, I know I started you on this medicine. I know it's expensive. What trouble did you have getting it? Were you able to afford it? Trying to be as open-ended as possible. So that would be the first step, is just to ask the question and acknowledge that these medicines are expensive. The second step to that, in my mind, is there are lots of resources to help with affordability that patients don't know about, providers don't know about, and they may be hard to navigate and time consuming. So the local SHIP counselors in North Carolina, SHIIP, those are folks that are funded actually through some grants that can help patients, specifically with Medicare, navigate which health plans are best for them based on their conditions, based on their medications. They can also tell you if you're eligible for something called low-income subsidy or extra help that can significantly decrease the cost of your medicines, but also the cost of your premiums. So that's sort of the second bucket that I recommend, is look into if they're eligible for extra help or low-income subsidy. And then the third bucket, if that one doesn't work, there are patient assistance programs that we can sign patients up for through manufacturers. So in my experience, through one of those different avenues, we are usually able to get the patients the medicines that they need and the medicines that their providers, think are right for them.
That's good advice. But if a patient's condition continues to progress despite all of this, what would be the next steps in intensifying their therapy? Like what role would, we talked about lifestyle modifications, but when we talk about, pharmaceutical interventions for blood pressure control and statins, how do they play in this process?
Yeah, sure. And, like I said, we have several classes of medicines that are synergistic and can be used together. If you look at the ADA, the American Diabetes Association guidelines, there are really nice charts that can walk a provider through how you would want to intensify therapy. So, for example, if you have someone on those traditional ACE inhibitors or medications for blood pressure, then you can add on an SGLT2. And you're wanting to use these medicines at their maximally tolerated dose. And then if they're on that one, and again, this is where that monitoring of that albumin or the microalbumin in the urine comes into play. You're going to need to continuously monitor that about every 6 months to make sure the medicines you're working are being effective. Then you can continue to intensify those therapies. The other thing that I would say is that, if you're measuring someone's albumin in their urine, that in and of itself is an independent risk factor for cardiovascular disease. So even if the person didn't have blood pressure issues or didn't have diabetes, that albumin in the urine indicates that something is going on in the vasculature, that there's inflammation there. And so if it's happening in the kidneys, it's going to be happening in the heart. So then you start thinking, to your point, Thomas, how can we just have general cardiovascular protection? So I think this is where you really need to think through, are we being as aggressive as we can with lowering their blood pressure, right? You're going to have a lower blood pressure goal, 130/80. You're going to want to make sure that you have the person on the highest intensity of statin they can tolerate, because they are at higher risk of cardiovascular disease. There's a strong connection between the kidneys and the heart. So there's lots of therapies that we can use these days.
That's great. Well, Rebecca, as we wrap up this conversation, it's always a delight talking to you, by the way. I really enjoy these because I learned so much from you. But what are the top 3 takeaways, for lack of a better term, that you'd like the healthcare providers that we work with or that happen to be listening to this conversation, what should they keep in mind when managing patients with diabetes to prevent or at least manage chronic kidney disease?
I think the first would be is that early detection is so important, right? And that's where it comes down to the screenings that we do. And, it's so important that they are part of our quality measures that we're getting graded on now, because again, chronic kidney disease is preventable, but you have to catch it early. If you rely on your memory to do it when you have a patient coming in and asking 10 other things, it's probably not going to happen. It has to be part of your processes and your procedures. And just allowing your other team members to help you out. So I think that would be first, is early prevention and having a process to have that as a standard of care. The second would be just realizing and having some education around all the medications that are now available to treat chronic kidney disease. So just educating yourself on that, whether it's a continuing, education event. I'm happy to do more of that type of education as well. Or even working with, your local pharmacy team to learn more about that and the medicines and how to get those medicines for patients. And then if I had to pick a third, I would just make sure that people are thinking more broadly about how we can protect kidneys and kidney health. So as you mentioned, there are lifestyle things that we can do. Getting people to stop smoking, one of the best things you can do for anyone's health, right? Not just chronic kidney disease, but all the health conditions. So making sure that we're assessing, doing the 5 A's. When I was seeing patients, I would always say, hey, Thomas, I know we've talked about this before, but I'm going to ask you every single time you come in, are you ready to stop smoking? Okay. And then, depending on how that conversation goes, well, just let me know when you are, I'm able to help you. So asking that question every single time, not forgetting about the lifestyle, as supportive as people want you to be in that moment, around those lifestyle changes. And then the statins, the intense blood pressure control, there are a lot of things that we can do that are really past those diabetes medications.
Awesome. Well, like I said, Rebecca, it has been a pleasure. So, Rebecca Grandy, thank you for joining us today on the Move to Value podcast.
Yeah, thanks for having me, Thomas.
This is the Move to Value podcast, powered by Chess Health Solutions. We hope you have enjoyed this episode. If you would like more information about this and other episodes, you can head over to movetovaluepodcast.com to check out all of the available resources. If you're interested in continuing to hear about value-based care and how it impacts you, you can sign up for our email notifications or subscribe to this podcast on your favorite podcasting platform. Also, we would love it if you would share the Move to Value podcast across your networks and leave a rating or review. Thanks for listening.